This is Dr. Caroline Peterson with Natural Women's Health Institute in Sarasota, Florida. Today we're talking about female urinary retention. Sometimes it's called bladder retention too. Urinary retention is characterized by the inability to void spontaneously. That means pee spontaneously, and or that you can't pee it all out, that there is a post void residual of pee in your bladder. So, one of those two things. People can suspect that they may have urinary retention if they have pain in their lower tummy. So, suprapubic pain, that means pain um, in the up from your bone in the front of the pelvis, the pubic bone. You may feel like you can't empty your pee all the way. A lot of people will have to move around, kind of change their position, put their hand on their bladder, move the bladder around to try to get it to empty more fully. Urinary retention is also characterized by having a weak stream, and so it takes a long time to pee. It doesn't come out very quickly. Can also be characterized by urgency, like all of a sudden you really, really have to go. There's no choice about it, or actually losing control of your pee entirely. So this is thought of typically as a condition of men because of benign prostatic hypertrophy, creating bladder retention. However, the idea is that it probably is much more common in women than we think of right now. So it's probably one of those conditions that's underdiagnosed just because women don't talk about it. They accept it as normal. People think of women as having like small bladders or having to pee frequently. And so these types of things can kind of, when they're normalized, they kind of hide the possibility that there's bladder or urinary retention. So what the literature does show is that about a third of postmenopausal women are going to have incomplete bladder voiding. And the other time that is very common is in the early postpartum after having a vaginal birth. Many times after having a baby, if someone hadn't peed in the first hour, then we would have to catheterize them to get that pee out, because that will also help slow down the bleeding and let the uterus come into itself and contract. Even more common postpartum is then the vaginal delivery causing the incomplete emptying is the cesarean. And so early postpartum is very common for women to have urine retention. It's also common after pelvic reconstructive surgeries and incontinence procedures. And so you always want to kind of keep it in the back of your mind when you're taking a history on a person, or if you are a woman, you want to be thinking, oh, if I don't have a strong pee stream, if I have to move my body, if I have to lift my bladder, um, I could have urine retention, and that's something important for me to address. So the typically urinary retention is diagnosed by an ultrasound. It's checking, like, after you pee, do you have pee left in there? The If you can't pee on your own, they would catheterize and do an ultrasound that way, and see if all the pee is gone after catheterization. So this is your normal bladder. So at the top in the middle, you see the ureter. These are the tubes that come down from the kidney to the bladder, and they fill the bladder up with pee. The bladder is covered by the peritoneum, which is the connective tissue that kind of organizes the abdomen, the whole body. Well, it's in the abdomen, so you can say abdomen. It's a fascia, basically. And then the top of the bladder is the detrusor muscle. And the detrusor muscle is the one that squeezes down, pushes down to get the urine to come out. Inside of the bladder is rugae, and so that's the muscles that are like this, same as in the vagina, so that they get folds, like curtain folds in them when the bladder's not full all the way, and then as it expands, it's gonna kind of flatten out. The rugae will not be there, and so just a way of kind of organizing space. And then in the bottom of the bladder, you have the trigone, which prevents the urine from coming back up after it's gone into the urethra. The urethra is the tube that takes the pee out of the bladder, and it has an internal sphincter and an external sphincter. And both of those are important. So for normal peeing, what happens is when about a cup, less than your bladder, you may have a sensation like, oh, I could pee. But then you should be able to inhibit that, and you should inhibit it, and let the bladder continue to fill. And then by the time you have about a cup and a half or a little bit more of pee in the bladder, then you're going to feel like, I need to pee. And so you should be able to suppress the need to pee up to about 2 cups. And then you probably really need to pee, can't, because the bladder can't really stretch more than that. So what's required for peeing is that the bladder needs to have a certain amount of pressure in it. That's pressure from the detrusor, the muscle above it. If this pressure has to be engaged in order to be able to push out the pee. So there's a whole bunch of nerves that are involved in peeing. So to be able to store the pee, that means make the bladder into a bag that's not leaking out. That's sympathetic largely. So that's coming from the thoracic spine, T10, 11, 12, and the upper lumbar spine. That will inhibit the detrusor muscle so it doesn't push out the pee. And then it will also contract the bladder neck and the internal urethral sphincter. It's the brain, that the prefrontal cortex, that actually is going to say, I think my bladder should act as a storage unit now, or now is time to empty. And so you need to have a strong brain. You need to have a strong cortex in order to be able to regulate pee properly. Also, the brain stem is very important for organizing peeing correctly. The pontine micturition center in the pons of the brain stem, it coordinates the detrusor muscle and the urethral sphincter so that you're going to have both activated at the right time so you can get the pee to come out in a strong stream. Emptying itself is under parasympathetic control, and that's the sacral innervation, S2, S3, S4, and that will stimulate the detrusor contraction and relax the internal urethral sphincter. And then the control, again, is in the pudendal nerve, which originates also from S2, S3, S4. And it makes sure that the external urethral sphincter opens at the right time. So this is a picture of how the brain stem, the autonomic ganglia, and nerve roots are related to peeing. So really, the whole nervous system is activated in a way for being able to pee properly. So when we're talking about urine retention, there are 5 different causes. Obstruction, neurologic, pharmacologic, psychological, and non-obstructive mechanical reasons for urine retention. We're going to go over each of those. So there are a number of different reasons for obstruction. It could be stenosis or narrowing, closing, hardening of the bladder neck, the lower part of the bladder. It could be constipation. A cystocele is prolapse of the bladder. And in my work, I also find that, any prolapse is going to be have an impact to some degree. So it could be rectal prolapse, it could be uterine prolapse too, that can influence the function of the bladder and the emptying of the bladder. Fibroids, so uterine fibroids can also influence the ability of the bladder to pee properly. Stenosis of the opening of the urethra. The meatus is the opening of the urethra. So if that's kind of adhesed, then that will be hard for the pee to get through. And then vulvovaginitis. So vulvo is the external genitalia, vagina is the vagina. And so if you have inflammation of that region, then it can also make it hard to pee. So when it's hard to pee, when obstruction is the reason that it's hard to pee, the bladder will stretch and the walls will get thick because it has to hold more urine, and because there's inflammation that creates fibrosis, a thickening of the walls. When there's fibrosis and an increased mass, you're going to have what's called reduced compliance. That means the bladder can't move as well. It can't stretch as well, and it can't squeeze as well to pee out. You'll have instability in that muscle in the top that's supposed to be the one that's pushing down to pee out, and then the contractions themselves are not going to be as good. So that was obstructive. Now we're talking about neurogenic urine retention. So this can come from a brain tumor, infection, trauma, stroke. Cauda equina is when there's injury to the lumbar nerves, cerebral palsy, dyssynergy of the detrusor sphincter. Diabetes can do it because it causes nerve death, genital herpes, and other kinds of nerve injuries from surgery. So these are things that are pretty advanced or very serious and probably are not going to be well treated by natural medicine. So basically what we're talking about, the parts of the nervous system that cause urine retention are the part that influence motor control. So influence the ability of that muscle to squeeze, influence the ability of the sphincters to open. So so that's the efferent part of the nervous system. That's a motor. So when the motor part is damaged, then you're not going to be able to pee out very well. So that can happen related anywhere in the spine. So spinal lesions can cause that. Sacral lesions can cause that. And so, if it's not a full-on diagnosed neurologic lesion, if it's something that's subclinical, then that is something that natural medicine, manual hands-on therapy, chiropractic adjustments can help with potentially. But if you have a brain tumor, that's not going to be something that natural medicine is going to be adequate at helping you with. So a big reason that a lot of people get urine retention is actually because of the drugs that they're taking, the prescribed drugs that they're taking. And there's so many different drugs that can cause the urine retention. The good news is that if you go off this drug, of course, with your doctor's assistance, then usually the symptoms will reverse within just a few days or weeks. And so that's really good news. The unfortunate thing is that many women are going to have an overactive bladder. And the treatment for overactive bladder that they will often give in biomedicine is oxybutynin. And oxybutynin causes urine retention. And so you may have taken care of your original problem, but then you have a new one. And so that's an unfortunate consequence. And hopefully we can find a workaround for that overactive bladder also, so you won't be stuck with that as we're dealing with urine retention. So one of the reasons, the psychological reasons for urine retention is called shy bladder. So feeling uncomfortable peeing in public or when people are around. And that's something that we can deal with neuro-emotional technique, a mind-body therapy that can help kind of identify why a person would have that shy bladder, why they wouldn't feel comfortable peeing in public, and then we treat that so that you can feel more comfortable peeing in public. Non-obstructive mechanical reasons. There can be a variety of causes, but usually it's something like a surgical cut into the bladder, something that's by accident. And so there's decompensation of the bladder. So it's super important to treat urinary retention. Like I said, maybe, a woman would feel like, oh, that's okay. It just takes me longer to pee, or I just have to pee more often, or I just have to move my body like this, or I just put my hand here and move my bladder like that, and it's okay. But what happens over time is that the bladder will decompensate. And when the bladder decompensates, what happens is that you're going to get reflux back up into the kidneys, and because the bladder's not going to be able to take all that urine, and so the kidneys you're going to get water on the kidneys or hydronephrosis. That's going to lead to renal failure, and then that can lead also, you can get kidney stones, you can get urinary tract infections. So it's not a pretty picture. And the earlier you can intervene, the better. So don't just think, oh, this is going to go away. Just get checked out and take care of it as soon as possible so that it's as uncomplicated as possible. So bladder decompensation results from obstructed bladder function. And it creates those fibrous, non-compliant bladder walls, low capacity, and then the detrusor muscle becomes ineffective. So it's hard to push out the pee. So once you have fibrous tissue, it's much harder to reverse fibrous tissue than to prevent it from forming. And so that's the idea. We want to prevent, we want to intervene as early as possible, take this seriously. It's a really Trilio thing. And intervene as soon as possible. Otherwise, if you have waited longer, that's okay, because we have some strategies for working with the fibrosis also. So the stages that precede bladder decompensation are, at first your bladder will try a workaround, it will compensate, and then it will become destabilized, and then it will decompensate. So it's a process that can take place over months or years. So bladder compliance is the change in volume divided by the change in pressure in the bladder. And you want that to be between 12.5 and 40 milliliters per centimeter of water. So a loss of compliance means that you have a low compliance. So the intravesicular or pressure inside of the bladder is low with a loss of compliance. This is the opposite of bladder overactivity or hypersensitive bladders that have to pee a lot. with those bladders, the pressure rises even when the bladder filling has stopped. And so it's a high pressure situation. And so you're always feeling like, I have to pee because the pressure is too high in the bladder. And when there's a loss of compliance, biomedicine will typically intervene with drugs to try to get the nervous system to respond differently. Sometimes they will implant devices like the sacral neuromodulation or the tibial nerve stimulation. Sometimes they'll do the Botox injections, and sometimes you'll end up having to catheterize. And sometimes they'll do a surgery to enlarge the bladder. In natural medicine, because we're not going to see people that will probably need catheterization or hospitalization, we're going to see more early stage cases, and we're going to see probably um, less trauma, so it's a more simple workup than you would have if you need to go to the hospital. So definitely, like if you have an infection with a fever and stuff like that, that's something that we wouldn't see. You would have to go to the hospital for that, because with the kind of profile that we're talking about, that can lead to sepsis. And so that's going to need some serious care in the hospital. So we're not seeing that kind of thing. We're gonna see more things that are, not trauma related, not surgery related, stuff like that. So the first thing we're going to do is take a really good history, because most of the reason that we can figure out most of the reason that you have the problem with urine retention just by talking about it. So we'll be finding out, what is the pattern of going to the bathroom, both peeing and pooping. Um, and do you have a history of trauma? Do you have a history of disease? So like let's say if you have diabetes, let's say an advanced uncontrolled diabetes, then that's probably neurologic. And so that's probably like too advanced to be able to address with a manual hands-on therapy and herbs. So that's something that probably will need more intervention than we can give in natural medicine. So we want to identify the probable type of urine retention. We'll do a dipstick to make sure that you don't have an infection, because of course, with retention, you're going to have a higher probability of getting urinary tract infections. Also do lab work to make sure that your kidneys are still functional. If the kidneys have lost capacity, if they're not as functional, then that creates a sense of urgency, because we don't want the kidneys to fail. So one of the first things I'll have you do is a bladder diary for 2 or 3 days, and that's writing down what you eat, what you drink, and when you pee, if you had a sensation like you wanted to pee, how long, how many seconds it took you to pee, how much came out when you did pee. If you had multiple voids, so let's say you started peeing and then it seemed like you were done, and then you got up and then there was more, or you waited a second and then there was more, like how many pees after the first pee did you have? Did you have to change your body position? Did you have to change the bladder position to get out those extra pees? So those are the kinds of things that you'll talk about in the bladder diary. And then I'll do an abdominal and pelvic exam. I want to see what's happening with the kidneys, what's happening with the intestines, with the bladder itself, how mobile it is, if there's adhesions, where the uterus is, how full the rectum is. The intrapelvic exam will check to see if there's any prolapse and what part that's playing, what the tone is of the pelvic bowl, the pelvic floor. And then if indicated, then we'll refer out for post-void residual urine volume testing with an ultrasound. If it seems like there's a neurologic etiology, then we can refer out for urodynamics, or checking the pressure flow, checking the innervation of the muscles, Probably you would be seeing like a urogynecologist at that point. I would probably refer out for all those things to a urogynecologist and probably transfer primary care to them and then supportive care from me. So this is an example of the daily voiding log that you would be given. You could even do it now, and just see where am I at? What is this looking like? And then the treatment options. So when we think about the 5 different reasons for urine retention, the obstructive reason commonly can respond well to manual therapy and herbs. The neurologic cause probably needs biomedical intervention if it's something diagnosable. If there's a neurologic component that's not biomedically diagnosable, so let's say nerve root or autonomic ganglia, that I can palpate and see that this is not functioning up to par. We can work with that, and that possibly can definitely help. The pharmacologic, great thing, as we mentioned before, that self-limiting. If you, under the care of your doctor, go off the medication that's causing the urine retention, that will self-resolve, and then we can work with whatever's left. Usually there'll be an obstructive component that's left after that we can work with. The psychological reason for urine retention can be addressed with the neuroemotional technique, NET, mind-body therapy. And then any kind of non-obstructive mechanical reason, that would be more like a biomedical intervention. And as we mentioned before, biomedical intervention uses pharmaceuticals to help modulate um, the, the, the muscles and how they work in the bladder. It may use the botulism injections, may have to be catheterized, or they may do the pudendal neurostimulation or the sacral nerve neuromodulation. So if you have a kind of stenosis, which is a sort of fibrosis that decreases patency or openness, then manual hands-on therapy can be helpful with that. Also, castor oil packs are wonderful for any kind of fibrosis, adhesions, or stenosis. And so putting the castor oil packs on the lower belly is great. You can also do internal castor oil packs, kind of like a flannel plug. That's kind of like a tampon that's been saturated with castor oil. You could wear that at night and take it out every day in the morning. Evening primrose oil can also help with like that meatal stenosis. If the opening of the urethra is fibrosed and closed, then you could take a evening primrose oil gel cap, puncture it, and insert a couple of those into the vagina each night. And sometimes that can help to soften and open the stenosis. For constipation as a cause of urinary retention, there are lots of reasons that people can have constipation. So you want to make sure the basics are in place, like getting enough water, having enough fiber, enough fruits and vegetables. If you eat grains, having whole grains, things like that. Many times magnesium citrate will be something we'll add on board right away because that brings water into the colon so that it's easier to poop in the morning. Triphala is an Ayurvedic medicine that has 3 different herbs in it that help to stimulate motility in the gut and also tonify the gut so that it's easier to move things through. Gallbladder, the bile itself is a huge motility factor for the gut. And so if you have any kind of gallbladder problem, then we would want to take care of that and improve bile production in the liver and then bile flow into the small intestine. Serotonin is actually one of the major things that improves motility in the gut. And so we want to make sure that gut production of serotonin is adequate. And then it is the intestinal motor unit that actually moves things, the food through the bolus, through fecal matter through the gut. And so working with visceral manipulation to optimize the motor unit function is super helpful. Of course, you have like a bunch of valves in the intestine that need to open and close, so that if they're not opening and closing properly, then that can also be a contributing factor for constipation. So looking at all of those things, working with the hands to get the tummy to start moving the food through better. And then if we're not able to make enough of a change quickly enough, if you're super backed up, if it's a super chronic thing, then colonics can be an awesome benefit for some people. So that's when a tube with water is put into the anus, and then water goes into the colon and then comes out and pulling out old fecal matter with it. So I don't always recommend colonics because they of course will alter the microbiome, and also they can irritate the internal venous plexus in the rectum, and so they can be a risk factor for hemorrhoids. They can irritate the autonomic nervous system, and so it can be it can be it's not for everyone. And so I use colonics judiciously. Sometimes they're very, very helpful. So bladder prolapse, really, um, uterine prolapse or rectal prolapse also can cause urine retention. And so um, I always start for any kind of prolapse, I start working on the tummy with the organ to get as much lift as I can to decrease adhesions. And then starting to work with the apical ligaments of the bladder and the uterus to get those ligaments to rise up and lift up the organs out of the pelvis a little more, because a lot of the apical ligaments are going to insert to stabilize the bladder and uterus on the pelvic wall. Then we want to make sure that the pelvis is well adjusted, so that there's not any kind of torquing or biomechanical issue in the pelvis, so that the uterus and bladder can lift up. Of course, constipation really influences a rectocele. Um, and so after we work with the tummy, then I'll start the pelvic bowl work, which is working to balance the muscles, making sure that the movement of the pelvic floor is correct with the breath. And so most people are going to need retraining of their breathing. They're going to need retraining of their core. They're going to need retraining of kind of like reflexive motions, like what happens with a cough, a sneeze, a laugh. Most people are not engaging the postural muscles correctly with that. And so there'll be kind of like a blowout, which is a pushing down and out. And so that is going to just, you can't just, that's going to just push down the pelvic organs again until you get that breath pattern and those reflexive patterns corrected. And so all these things kind of have to happen at the same time. So bladder inflammation is another reason for retaining urine. So this sometimes can be as a response to bladder obstruction. And so there are herbs that we can use to decrease the bladder inflammation and hopefully prevent fibrosis, or some of these herbs are actually good at also treating the fibrosis. And so for us in natural medicine, to decrease the inflammatory response, which is good when it's initially turned on, but it needs to turn off. The problem is when inflammatory responses are not turned off. That's the issue. So what we'll use is the curcumin, ginseng, EGCG, quercetin, resveratrol, andrographis, and then some other particular components of other herbs. And then for the bladder wall fibrosis, as I mentioned, some of those herbs that we use to treat the inflammation of the bladder wall will help with the fibrosis. And we can also add in the hanokiel from the magnolia. And so the visceral and neural manipulation is super important along with chiropractic adjusting. So we want to make sure that T10 to L2 area of the spine is working properly, moving properly, also the sacrum. And so we can work on the joint level, we can work on the nerve level, we can work on the fascia level. Less commonly, I mean, the muscles pretty much take care of themselves. It's usually fascia that's involved. And then we have the autonomic ganglia that also need to be addressed in some cases. With craniosacral therapy, we can also work on the micturition center and the pons and the prefrontal cortex. The pudendal nerve and the hypogastric nerve can be addressed with the myofascial release. A lot of time, I always check the organs that are related and their movement patterns, their positioning, things like that, trying to optimize motility and mobility of the organs. So the kidneys, of course, the ureters, the tubes that go between the kidneys and the bladder itself, the urethra with tube that comes out of the bladder. Of course, the uterus and the ovaries, the whole GI tract, the pelvic bowl, and then of course we have to include draining of the pelvis and usually the abdomen too. So then we're looking at the venous system and the lymphatic system. And all along the way, what we're really most of the time dealing with is adhesions and fibrosis that are not allowing the body to move properly. So in conclusion, um, in order to successfully treat urinary treatment from a natural perspective, we really have to understand the cause of what we're dealing with. And so once we understand the cause, then we're going to treat that cause. And then we're going to be able to enter in with manual therapy, botanicals, and then changing breath patterns, changing muscle engagement patterns, and hopefully helping you come back to just feeling like peeing is a normal part of your life and that you don't require any special activities to be able to do it. This is Dr. Caroline Peterson with Natural Women's Health Institute in Sarasota, Florida.